So, as we're nearing the end of what I think has been an absolutely amazing experience for us all, I keep saying amazing because there's been so much engagement from everyone. We've had incredible speakers. We've had incredible support from many of the students who are studying oral health and other students as well. So we're going to now run a panel, and our CEO, Demos, is going to facilitate it and sit on it and lead it and... and I will just let you know who is sitting on our panel, because we've had some extra special visitors arrive as well. So I'd like to first welcome Tom. Tom Symondson is a politically astute leader with a track record of achievement across a range of sectors. Well, I think it's true from what I've heard from you today. He actually comes from the UK, and he's got an eye for the bigger picture, and I think we're really lucky to have him along here because he has worked across a whole range of sectors and not only health, and he's worked in the political environment as well. So welcome, Tom. Thank you for joining us. Dr. Martin Hall has finally sat down and is there at the end of the table. Martin graduated as a dentist, actually, in 1980 from Adelaide, and he's worked 35 years in public oral health in many, many different sectors. Everyone's bio is up on the website, as I'll remind you, so you can study it at your leisure. But Martin's been the manager of the oral health program here at North Richmond Community Health for the past 20 years, and he has been an amazing mentor for all of us that have worked here, both past and present staff. And I'd like to acknowledge his support and his commitment to the work that's done here. And I'm not going to get emotional, don't worry. I think if it wasn't for Martin, we wouldn't have what we've achieved in the last couple of days, and I really think he deserves acknowledgement as the leader that he is. Okay, I'll stop. It's all right, you've had enough. Deb, on to you. Deb, thank you very much for being here and supporting us in all this work that we're doing. We really do appreciate the fact that you have been here all along with us throughout these last couple of days, and appreciate your commitment to the work that we're doing and the work that we know that we can share and achieve together. So thank you. Deb is the CEO of DHSV and also is an Adelaide graduate. Yes. I'm still meeting lovely Adelaide graduates as I travel around talking about the Hall technique. Bendigo have quite a few Adelaide graduates, so yeah, they're wonderful people. Katie, yes, fantastic. So Julie Barker, I have co-opted into sitting here with us. Julie is the immediate past president of ADOHTA and wears many hats also, is involved with the Alliance for a Cavity-Free Future that some of you would have heard about briefly this morning, and is very committed to many of the issues that we've discussed, and I've noticed has been very active on Facebook, which is what Julie and I are doing a little bit of work on, and talking on Health Pro Exchange and various other forums about the great work that is being done in the oral health sector. So thank you, Julie, for joining us. Bernadette, we've been blown away by your enthusiasm for complaints.
Actually, that's not quite right.
Thank you very much for joining us at the last minute as well. And then Demos, I've just been so happy with your support, and thank you very much for jumping in there, doing everything, facilitating, getting us all involved, and I'm going to hand this over to you now.
Thank you very much, Rachel. Thank you. Okay, so as I said yesterday, I really want to be Tony Jones. So this is Q&A. This is a Q&A session. Unlike traditional Q&A, we really don't have quite a theme or single theme, but we've got many themes. And the themes are all the things that we've been talking about for the last day and a half. And all of you have participated in all these wonderful presentations. So it's now really over to you. And if you would like to also text us a question, I think the text number is up there somewhere. Is that right? Yes. So you can text a question as well. But this is your opportunity now to address a question either to the whole panel or an individual on the panel. So over to you now. Who would like to start us off? Come on, all you brave people. Yes, over here. Thank you very much. Just introduce yourselves.
Glenda Farmer. I'm a private practitioner. I work in the different part of the world. I see totally different people to the people you see. Anyway, my question is really for Deb Cole, and there might not be anything, but is there anything that you've experienced over the last 2 days where you think, I'm going to take some definitive action out of that, or too early to process?
This 2 days is at a really good point in time, because I think there's a lot happening in the health sector at the moment that's making CEOs like myself rethink about the way that we do things. And it's very clear that making sure that the consumer and the patient and the people that we actually care for get the best possible care has got to be our focus. And I think that, and I think I said this yesterday, if we keep doing what we've always done, we'll always get what we always got. And we know that that's not ideal. So we do need to be tying in that whole mindfulness, thinking about how it's going to be done. And from my perspective, and this is sort of without any discussion with anybody further, there is definitely something here. I'm not quite sure what it is yet, and how do you roll it out for a whole organisation, recognising that in Victoria we're actually 53 separate organisations that are independent, and how do you actually move something and change something? But you actually have to start, and I'm fairly convinced there's something in it, but how do you do it on a huge scale? So yes, I think there will be changes. What they'll be, I've no idea. But a lot of the comments that I've had from people in the last couple of days will really all go into that. And I think we as an organisation are just about to go through our next tranche of strategic planning, where we want to engage as many people as possible. And I think this will be a real opportunity to look at doing things differently.
Sorry, you're probably all wondering why the hell I'm here, because I'm not a dentist, I'm not a clinician, and I have absolutely no involvement day to day with the work that you do, except that I run the peak body for all of your employers, unless you're in the private sector, and then I'm afraid that I don't. But both DHSV and Demos and all of the other community health services and hospitals are part of my organisation. And the thing that, so I haven't been here for the conference, but I can imagine some of the things that you have been talking about. And the opportunity that I think is coming now is that you have planets aligned around everybody talking about oral health as though it's something that matters more broadly. So when Deb's talking about her strategic plan, and you're talking about how you can influence probably your employers to be more focused on this as a set of issues, together, if we're all talking the same language, we at the VHA can say, actually, oral health's a priority for all of you, therefore it's a priority for us, therefore it needs to be a priority for governments and politicians and policymakers. So one of the things that I hope an event like this has encouraged is people to start to push oral health more broadly as a priority. So it's not just about seeing the client or the patient, it's about saying, we've got a much broader impact that we can make in the holistic health of this individual, and we can only do that if we're all talking from the same sort of hymn sheet, which is why I might be here for a vaguely positive reason, which is to say, we think as a sector that oral health is important, but we can only push it if you're all pushing with us.
Anybody else would like to? Okay. Questions? Other questions? Anybody else would like to pose a question to the panel? Thank you.
As a qualified oral health educator from a different community health centre, my skills are being grossly underutilised. There is nowhere, it's all curative, unfortunately, based models of care. That's how the funding structures are modelled. What can I do to help inspire change, not just through my education and other nurses that are educated, for us to help make a difference in the community with preventative care? Is anyone able to help?
Very good question. Who would like to tackle it first? I'm not looking at you, Deb. Martin, perhaps.
Well, I've suggested that you get together and organise and make a bit like Tom. If you make yourselves known, you highlight the problem and come up with a solution, and then discuss that solution with people who can make a difference. Then there is hope. I'm in the broader context of this conference. Sort of a message to the program managers is mindful management. And I had a bit of obviously been thinking about this in a mindful way, and it's so important to. It's so important to have some sort of strategy or vision, and I wanted to draw this because we have to balance so many things, as program managers here will know, and to do that in a mindful way. I'll just go back to grade 7 mathematics, and what we tend to focus on, and it came out yesterday, was financial. Okay, we always say we can't do things because it costs too much money, or we've got expectations. We hear about DWAs, and we all hate DWAs, but it's part of the formula. And then we have people, and the people need to be looked after as staff, yourself, your staff, and your clients. So there's a lot of thinking about people and how they're looked after. And then there's this other stuff called, I'll put it down as innovation, or professional purpose. And somehow or another, you've got to try and get to this point in the middle where they're all balanced. And it's a juggling act, as all the program managers will know, but I think it's something we have to develop to progress, and even things like supporting oral health educators, because it might just lead us to this middle section. Small suggestions, innovations at all levels. So that's sort of my take on mindful management to the managers here. If that helps.
I think you've picked up on another one of my hobby horses, so well done. Certainly, I see this as all part of a model of care. And once again, one of the things that's really amazed me is that, and I know from DHSV, we've supported a lot of training for people to get these Cert 4s. We've also supported adult scope for oral health therapists and a number of other additional training. And I have to admit, I've been a bit surprised that, well, I'm not really, when I think about it, it was a bit stupid of me not to realise this, but I just assumed that everybody would automatically then engage people into their organisation and their structure, but they didn't. And I think it's, once again, people are really uncomfortable about the change, because every time you move this bit, then all these other things have to be changed, and it's too hard, which is why you have to have the conversations about the models of care. And the models of care aren't just about what treatment you're going to be. It's going to be who's doing what workforce does what, how do you work the patient flow in the day, who sees what when, so that you don't end up being inefficient as well. It actually requires the whole team working about it. I know Martin's team spend quite a lot of time discussing that, working out how we're going to actually make this work, logistically. It actually requires everybody to do it. So certainly from DHSV, we're starting now to go back to people that have got people with qualifications like you and say, right, how are you actually using people like this? We've supported their training. We want them to be used. It's actually an efficient way of doing it. And people say the funding model doesn't support it. I don't think that's true. That's just an excuse. We actually have to, Martin's absolutely right. Everything's a balance. Everything is, every decision you make, you have to compromise and not do something else. We just have to find the perfect balance. And it requires intellect and thinking, and you don't always get it right, but have a go again. And I think that's the model that we'd be very supportive of and have been for a while. But it does mean changing the way we did things before.
See, a system perspective here, the reality is this is happening across far more than just oral health. So I go and talk to people who run public aged care facilities, and we've got exactly the same issues with different types of staff not being used to their full scope of practice or their full potential scope of practice. So that's one issue, and we have to deal with that because we've got an expensive workforce if we're not going to use it properly. The second thing is that we tend to be very curative, and that's because our funding model across the whole health system tends to be based on widgets. So, how many dentures have you sorted? How many, how many hips have you replaced? How many whatevers? And so there are real funding barriers, but a lot of them are just in people's minds. So we have multidisciplinary teams. Community health is a wonderful platform. You've got all of the people who can do all of the other things that individual might need in the same building. And sometimes it's just that we don't utilise that. So from the perspective of the CEOs groups and the boards and the politicians, we're all saying, we need to move more into the community sector, we need to be much less acute, we need to be much less focused on curative and much more focused on holistic and well-being and all of those other things. But it can only happen if we start to prove that it's worth doing, because politically it's very difficult. People want to fund hospital beds because people understand hospital beds. They want to fund specific activities with very measurable numeric outcomes. So how do we become ambassadors as individuals for that kind of change? Because it makes it easier then for the people above us to go, well, let's give it a go. What happens often is that all of the different clinical groups tend to fight a little bit about who's more important and who's going to get the attention, and that brings us down. So if we can avoid that, that would be great. But from the policy perspective, what you're saying is absolutely right, both on the workforce and scope of practice side and on the prevention side, because we should be doing more of both.
I just want to talk from an individual clinician's perspective, because for too long the workforce out on the coalface feel as though that they are disempowered, that they have no ability to change these decisions that are being made. But the innovation is what comes from the workforce. You can't rely on management to be the ones to innovate. And this means getting out of your comfort zone, getting out of your little clinical area and making those links and those connections with people who are outside of your normal working group. So whether it be going and talking to the diabetes educators or whatever it is that will actually let you use your skills and knowledge more fully, just making those connections and finding out what can we do for you? How can we help you? And then taking that back to your managers and saying, look, I don't feel I'm being utilised fully. I've been talking to this group and they need help with X, Y and Z. Is there some way that we can put this into action? I'm happy to work out a plan with you so that we can go ahead and do this. But it may be something that your manager or the upper management, the hierarchy, haven't even considered. So don't think that you're disempowered. You have a lot more power than you realise.
Only from a perspective of a community member, really. I mean, I get what you're talking about. It's that early intervention stuff, isn't it, that I was talking about before. And it's just, my kids are grown up now, but I've got 2 granddaughters. And I don't know, I think lots of people in the community anyway, I don't know, in the higher echelons, but lots of people in the community understand the real importance of preventative stuff, of being proactive, and so it's a good sell, really, isn't it? And then at the other end, you save money, don't you? It's getting the money to do it in the first place.
fantastic responses. So I take from that all of these rules are socially constructed, and we can socially unconstruct them. Not all of them? So they must come from God, than the other ones. Okay, so thank you for your question. That's terrific. Okay. Now, oh, over there. Fantastic. Thank you.
Hi, I'm Michelle. I'm a dentist at Darebin Community Health. For me, it just seems that we need a new way of measuring productivity in dentistry, because productivity at the moment is all about doing stuff to patients, and there's no acknowledgement of whether that stuff is actually beneficial to the patient or not. It's just how much stuff you can do to them. So, I mean, what I think we need to do is find a way of measuring how much the patient's oral health improves and try to work a system that measures that as the productivity of what we do.
Is that on? It is on. Yeah, absolutely. Totally agree with you there. And there is certainly a lot of interest in shifting funding from output-based to outcome-based. The hard thing is, how do you determine what is a measurable outcome? How do you measure a successful outcome where it's going to be different from one patient to the next patient? But absolutely wholeheartedly support that we need to stop focusing on how many of these individual things we're doing, and look at what sort of impact that's having on the patient's life, and how else we can improve their quality of life.
So things like, your reduction in DMFT, for example, or reduction in periopocket depth and bleeding on probing and things like that. I don't know how you'd work it out, but to focus on those kind of outcomes rather than the individual stuff that you do to get there.
This is one of the things that we are struggling with across the whole system, because everybody knows that outcome is more important than output. Everybody accepts that that's difficult, and that's where we stop. We go, we need to do it, but it's difficult, so we'll think about it for 10 years, and and we. So we tend to use proxies. So from the acute side, it's how many people are on a waiting list, because if there are fewer people on a waiting list, everybody must be better and happy. And you're right, we tend to go, well, we've done this many widgets. That's a wonderful word, isn't it? Widgets, what does it even really mean? We've done enough stuff, therefore we have improved people's lives. But what we tend to see is that everybody's doing those widgets, whether it be an oral health intervention or an aged care intervention or an acute or whatever, on the same people. So not only are we not measuring outcomes from the perspective of your specific care type, we're not measuring quality of life outcomes for that individual in a holistic way. Because as soon as they leave you, they might have a mental health issue, so they go off to a mental health provider, hopefully within the same organisation, but that's not necessarily guaranteed. And we don't make any real attempt. It's not fair to say we don't make any attempt, but it's very difficult then to go, well, what has the cumulative impact of all of those things been? And what has that done to the quality of life for that individual? So I think the real challenge is that we actually have to start thinking ourselves, as organisations, as clinicians, what are the kinds of outcomes we want to be able to see from those individuals? Because the funding models don't encourage it. We'd be doing it despite the funding models, not because of. And actually driving those improvements ourselves and trying to get a bit of an evidence base, even if it's only locally, because it's very, very hard to do that nationally or at a state level, because people sort of, they do it for a couple of years and then they go, well, that was fun. We haven't changed the world in 2 years, shock horror, so we'll stop measuring it, or we'll stop trying to work out what those outcomes we wanted to see actually are, or how we can measure them. So I think the challenge is that we're trying, but we're not trying hard enough. That's not a very positive way to end. So come up with something positive, Deb.
Oh, we're one of those organisations that's not trying hard enough, no. Look, I've been on record at Senate committee inquiries and everything saying I think our current funding model is not acceptable. I don't believe we've basically got a fee-for-service type model, which is an output. It doesn't drive the right behaviour. All funding models drive behaviour, and this one doesn't drive the right behaviour. it has to be outcome-based. We are intellectually thinking now about how we might do it, but even things are used examples of things like DMFT. The problem with DMFT is that's such a long-term change that we know that we won't see that, that's generational. Although we do see it, like you look at Barwon Health, where they introduce, anywhere we see fluoride introduced, you can see a DMFT changing in a 5-year period. But that's pretty extreme, and fluoride will always get a more extreme result than most of the things that we do. So we're really looking at how you would do it, but actually costing it and pricing it will be really difficult. So we're actually looking at working with some health economists to assist us in that process, because it actually requires some of that intellectual grunt too. And our biggest problem is that, like with the DWALs coming in, that was a national thing, which is basically fee for service. It's going to be very hard to manage that. And I think, as Tom said, the issue we'll have is, while we might get all the intellectual grunt behind it, and I think this government's quite keen on trying something in this space too, this state government, we might end up having to have 2 funding models, which I think would be scary. Because that's one of the things that I advocated when we moved from DOVs to DWAs, that I didn't think the sector could manage having 2 funding models. We have to go to just one. And did I support a DWA one? Not really, but it was, you sometimes have to be pragmatic and go, what could we cope with? So I think that what you're talking about is the way we have to go, but it is really hard. And any people that could start thinking about it, because we are in that space now, but I think it will be a few years before we even get to something that says here's a model.
But yeah, I wouldn't be advocating doves either, because we found anyway in our practice there were some practitioners who would do a 10-minute exam, go, yep, you're fine, and then we'd see them down the track and they've just got caries everywhere.
Can I say that while I don't think Doves was executed probably the best, it needed some adjustment. The concept is actually the base we need to use, because Doves were an episodic payment system. What they didn't have is they didn't have the incentive to drive the right outcomes. So I think what we need to do is to find an either episodic or capitation type thing that gives you basic stuff for just basic care, and then work out how do we then incentivise people to provide good health outcomes. Just not quite sure how to do that. So I think the perfect model will be a sort of a Dove type thing, but with something added on top of that drives good health outcomes. So I know that Doves had a bad reputation, but there was some good in that. And I think one of the things that's really clear is we provided a lot less services when we had Doves than we do now. We provide a lot more services now per person.
Because we're fixing up all the stuff that was
left
when
wait a
there
minute.
were Doves.
You tell me which is good and bad. I am yet to understand what is good oral health. And that's a question we need to answer from the consumer's perspective, not from ours. And that's going to be a really hard gig.
I think a starting point, if you wanted to do something practical, work out who your high-risk client groups are, and then measure how many Fisher seals were done on your high-risk children. And then you can actually collect evidence, but versus how many Fisher seals were done on low-risk children. Waste of time, energy, no outcome. Lots of output, no outcome. So I think it involves model of care, and it needs to be considered who gets our care and what sort of care. I'd like to see more funding into evidence, practice-based research, so that we can actually come up with our own solutions. That's pretty much it. I just don't think you have to be practical as much as we all love to go for outcomes, but I think there's things we can do straight away.
Thanks, Martin, and the panel. Just on that, I think it's a really fundamental point, and I'll just come to your question in a minute. But do you think we've got the right people sitting around the table to consider this question. It seems to be... Is there any health economists in the room? Oh, we had a health economist. That's great. So this is often an issue, considered an issue for health economists, but I think you actually need even a much broader group than even just... It's just not an economic issue, but as the way that Martin posed it then, who benefits from the outcome is really the fundamental question to be answered. And that suggests to me a much broader group of... We need broader knowledge and broader input into answering that question. Okay, thank you. I'll just hand over to... Next question.
Mine's not really a question, but more a comment in addition to the discussion. I'm doing a project at the moment for DHSV about child recall and access, and I'm sort of trying to figure out where DHSV sort of obligations lie in terms of being a funding provider, but also a governing body, and how much exercise and control they have over encouraging certain models of care within the community agencies that are all run really separately, and how we could sort of brainstorm our way into an outcome-based measurement still under our output-based funding model. And we're looking at a caries risk assessment tool, and I was thinking that it might be a really good objective for general courses of care delivered in the public sector for adults and children if the primary objective of a general course of care was to reduce the risk status. And we can use a tool, South Australia's developed a caries risk assessment tool that automatically looks at your DFT, and we can incorporate perio information from titanium and have the computer pump out a risk assessment classification, and then we can compare information about what the change in risk is over the course of the general course of care, so that, yeah, that could be an outcome measure that we can all sort of strive for. It's pretty easy to just say, my priority is to reduce your risk status, and that be something that the oral health educators can get on board with, the OHTs can get on board with, the extended scope can get on board with, the whole. It's really easy to just decide that that's our primary objective and still work within our output-based funding model to achieve that.
I'll take that as a comment. Questions? Do we have a... Jesse's got a question there on the SMS.
Around the same ideas, as community dentists, we know the importance of minimal intervention dentistry. What's required to allow government policy to align with this philosophy?
I'll start with Tom.
It sounds like a technical question. I'm not here for technical questions. God help me, no. I think it comes back to that fundamental point that what we have funded are specific tasks or activities, and we're actually in Victoria very proud. We, I say we, the royal we, not particularly me, very proud of how good we are in comparison to other parts of the country at funding very financially efficient services. So, you know, we have had activity-based funding in our acute hospitals since the early 1990s, and other parts of the country are only just coming to that now, and that has sort of flowed through the rest of our health system. We're brilliant at delivering an episode of care or a specific activity to a very low price compared to other people, with a similarly positive outcome or a similarly not as positive outcome to other people, other places in the country. The problem is we've become a little bit intoxicated by that. So we look at our financial outcomes and go, well, this is actually pretty good. The federal government is trying to push everybody else down to a level that's not even as low as we are. And trying to persuade politicians that this is not necessarily leading to the best outcomes is actually relatively simple. Trying to persuade them to fight Treasury to change those funding models so that they're around, whether it be outcomes-based, however we define that, or something a little bit more holistic. That's the real challenge. So when I go and talk to the state health minister, she absolutely gets that we want to be more focused on the health of the individual and less focused on let's do the 15 widgets and somehow that'll make somebody better. But trying to have that conversation with the people who actually control the money, I think, is the biggest struggle. So I can't give you a technical answer on the specifics because they went a little over my head, but I can say that I think we've got a very long way to go before we persuade our policymakers as a whole, and I include, you know, senior bureaucrats as well as politicians, that the funding model is actually incentivizing things that might not even be in the best interests of our community, because it looks good from a financial perspective. And that's slightly controversial, but I think that's the reality. Do you have a technical answer? Technical response from someone?
I may have. Minimal intervention dentistry is trained in all of the universities. All graduates come out with that knowledge, but they seem to lose it for some reason. And it's not just funding models, lack of mentors, lack of policy within the health sector or the programs themselves, support for that type of dental care. So I mean, the evidence is there that minimal intervention is the correct way to do dental work. But what generally happens is dentists, and as the leaders of the dental teams, use professional judgment rather than evidence to design their work and their day-to-day practice. That was more than a comment, but I'm happy to hear other comments about that. Yes.
I'd like to speak in defence of, not with the mic, I'd like to speak in defence of stupidity. So it's not just the dentists who get rewarded more for putting major output out, and they've got to cover their now $300,000 that they have to earn, but it's the patients. So the patient would rather go to the preferred provider, get the fluoride they didn't need, the prophy they didn't need, the checkup they didn't need, the bill that they don't have to pay for $250 and go, I've got no gap, rather than going, actually, I didn't need any of that. So we're not actually, it's human nature that you're actually going against, not necessarily governments and things. People also choose to do the wrong thing because they think they're getting an economic benefit.
So consumerist view about that. Any comments from the panel? Perhaps at this end.
Can I just say that absolutely support funding models drive behaviour, and it's the same with if you've got an insurance, if you've bought an insurance package, a health insurance package, that will drive your behaviour too. So not only the suppliers of the services are driven by the funding thing, but so are the consumers. But that is humans, that's what we do, and that's why it's really important when we design the future, we actually take into consideration that, but take it into consideration from the consumer's perspective too. So I don't think that's stupidity, that's human nature, and we should, you know, don't shy away from it. Then that's not bad. That's just what people do, and that's okay. But then we need to be thinking about what's the way forward to actually make it better, so that more people can access services.
I've never heard of minimal intervention dentistry. So, and I'm just saying, like I'm an ordinary person, and if I didn't have to, I don't know about anybody else, but if I didn't have to go for checkups every 12 months or whatever, and I mean, my teeth are probably different to, young ones these days, but, well, then I wouldn't. So I need the information. I need the information to make the choices for me. And when it's not, presumably, it's not out there for me to understand that, because I have a different understanding.
Okay. So, I am on the Minimal Intervention Dentistry National Working Party group, and we have been trying for a long time to get the information out there. So we're coming up against brick walls with, okay, the universities are teaching it, but the practitioners aren't practicing it when they get out. They're not being supported by their managers to practice minimal intervention, and they're not providing the information to the consumers that there may be a different way to approach this issue. You know, gone are the days that was, you know, we'd do an examination because we were looking for holes, number one, and then we would want to fill the holes. You know, now we are looking at an assessment of that patient's oral health status and trying to predict how that's going to progress in the future and how we can help them to maintain caries-free status, or at least get them back into a stability that rather than an active caries or an active disease process. We are looking at how we can also co-opt other members of the health team to help deliver that minimal intervention message. But it needs everybody. So it needs all of us here to be going out and talking to our patients about minimal intervention, to be talking to the people we work with. Our dental assistants can be some great advocates because they can pass the information on to the patients, and the patients often feel a lot more comfortable listening to the dental assistants talk to them rather than the professional delivering the same message. We need to talk to our health colleagues. We need to talk to education colleagues. Anywhere and everywhere, we need to be getting out there wherever there is some sort of public consultation or anything on health. We need someone popping their hand up and going, you know, there's minimal intervention. There are things that can be repaired. There are things that can be remineralised. There are steps that can be taken. You know, dental caries is not inevitable. And if we're not delivering that message ourselves as the oral health practitioners, then we can't be expecting our patients, number one, to be asking for it or even understanding what it is to be able to ask for it. So there's lots and lots of research going into it, which is great. There is a fantastic evidence base. We've already got the evidence to support it. We just need to be the impetus to push it.
Yes, of course.
I'm Marcella, and I work here sometimes on a Friday, I do. But I also work at RMIT University in training dental assistants to become oral health educators, and have done that for a number of years. And the problem is that this is a big circle. I can just see this discussion is going round and round and round and round and round and round, and nothing's going to happen. The dental assistants become very frustrated because they're the lower end of the pecking order in most dental practices, and they're not listened to. So here they are being trained and being well trained to be able to participate in patient management and minimal intervention practices, but they're not listened to. So we have people that are frustrated because they're trained. Here we go back to this discussion again, but the managers aren't listening to them. Perhaps dentists are threatened because they see them as just dental assistants. They don't appreciate or respect the fact that they are trained to perform a certain function. So it goes back again to here we have the people at the lower end of the pecking order, and I hate to put it that way, who are trying to achieve something, who are trying to use their abilities, but they're not being listened to from the top down. So it comes back again to that circle. They're pushing a barrow uphill, but they're not being listened to because they're being pushed down. So what is it? What can be done? You know, is it the managers of all the community clinics that need to be trained and need to have their eyes opened to see the talent that they actually have in their organisation that's been wasted? So I just see it as a big circle going round and round again.
Thank you, Marcella. And I'll just go back to a quote I use a lot from, I think it's from Martin. I think, Martin, you said a number of years ago, in the future, will the dentists be assisting the dental assistants? And I thought that's a very provocative quote, so I'll start with Martin this time. Because he did use, I think I attribute that quote to you, Martin. So. Might not be true, urban myth.
I'll accept that. I think it again comes back to this Venn diagram behind me. If you're not doing mindful management and you're not looking after your staff, then you can't run a practice which is going to have any outcome, really, any successful outcomes. You'll keep churning through outputs, you'll have frustrated staff who are stressed, don't turn up to work, all the things we learnt about yesterday with Craig. and applying mindfulness to your work, looking after yourself and then being able to look after other people. I think it applies to program managers as well, taking a step back and saying, I need to run this practice in a mindful way and consider these things. We have to consider everything, but don't leave people out. And I mean, I'm trying to practice that, where our model of care does respect the dental assistants, and they have more than equal rights, I think, to contribution towards the client outcomes. So I try to practice that, but how do we get other people? I think you have to have the evidence to start with, and we're hoping to get evidence to say that we do have a model that is economic and does have positive outcomes for clients and isn't treatment focused, preventive focused. It's a small part of a big, complex health system, but we would like to be able to influence that through evaluation. I could go on, as you know.
Just before we do, is there a dental assistant here that would like to make a comment? Yes? Because I think it's important to hear. No?
Okay, I don't know quite how I'm going to word things, but I can honestly say that, because I've worked in private for many, many years, and I think there is nowhere else that I've worked where I think the DAs have felt so much a part of the whole team and valued. And I'm not just saying that to promote North Richmond, but it is a fact. And I think that the model of care is really the fact that we're encouraged to get involved and to promote it and everything like that. I think it's just really, it's really great to be part of it. And yeah, I guess it's just a matter of spreading the word and holding more sort of seminars with encouraging other community health clinics and even private health clinics as well to really take on the extended scope of the DAs and to get the word out there. Because I think a lot of the time, especially private clinics, they're just naive about things. They don't actually know what goes on in the bigger world. They don't know these things are available to them. And it can actually be an extremely economical way and client-centred way of treatment, and yeah.
I'd just like to follow up. One of the things I think, and that's where North Richmond have done a really good idea, is with the model of care, you actually have to document your discussions, because it just doesn't happen. Things like these major changes of empowering people don't just happen. And actually, it's taken, Martin, a long time, hasn't it? All of you and your team, and you've all been actively involved in it. And I've heard, that didn't work, and we've tweaked this, and it actually isn't easy, but you've got to start the journey. You do need to document so that you've got some idea of how to do it. And just another thing, I'm just putting in a plug now. We've got our public oral health conference next year. We've actually moved it by popular request to not in the middle of winter, to a Friday. I think it's the 6th of May. But one of the keynote speaker is going to be talking about hierarchies in health and how that's how to break down those hierarchies. So it's all, as you can tell, it's all very consistent with the mindfulness and how do you actually bring everybody and empower them to make better healthcare for the consumers that we care for.
It looks to me that it seems like revival is happening. This is just a comment to all this that we were talking about. Yes, I'm working in North Richmond for many years, 15 years. I started as a dental assistant and progressed to dental hygienist. So we were talking during this conference for the last day and a half that it's all about our patients, patient-centered care. So we have to think Are we thinking about ourselves, about our hierarchy, or are we thinking about our patients? And it is about empowering our patients, giving them skills and knowledge to look after their teeth on daily basis, because that's what matters, what they do on daily basis at their homes. So which dentist in public dental clinic has a half an hour time to spend educating the patient, how they look after their teeth? So that's why we have to utilize our dental assistants, oral health educators, because they do have excellent training and knowledge. And as someone mentioned before from the panel members, that patients are less intimidated by those members and would be much more open to discussion and open to maybe receive the information.
That was a very strange experience for me. I opened my mouth and your voice came out of it. I thought I'd lost mine for a moment, but both. But the thing that really interests me about this, because again, I always talk from a system perspective, and oral health is a part of that system. Deb and I have a little bit of a habit now of going to Saturday conferences. So last Saturday, we were both at a conference run by the Australian Medical Association Victorian branch about bullying in the medical profession. And we've all read about this. You know, it's generally surgeons who are much more experienced and generally older being accused of bullying new entrants to the profession, or men bullying women, or a whole heap of very unpleasant things. And it sort of makes me think about the fact that we've got a hierarchical system for some very good reasons. Not all of those reasons are current. So, you know, we created a disease prevention health system. That's what we have. So we've got hierarchies in place. If you're in nursing, it comes from the military model, so you've got hierarchy because of that. Then you've got doctors making decisions that nurses can't make, and then you've got exactly the same thing happening in oral health. We as a system have a hierarchy that is not necessarily fit for purpose today. And I think the point that I want to make is this is not just the case in oral health. It's the case across all of healthcare. And the positive note is that we're coming to a pivot point where that's no longer going to be tolerated. So the AMA, the representatives of the doctors, are actually saying bullying in the medical profession is not okay. This would have been unthinkable 10 or 15 years ago. Yet now it's getting popular weight behind it, and you have ministers talking about it and saying it's just not good enough. So whilst that's not directly applicable to you, the outcome of it will be that the kinds of issues that you're talking about, where we're not using your skills as an educator, where we're not using people's skills but we're paying them as though they should be using those skills, it won't be tolerated anymore, I hope. I'm very optimistic, maybe stupidly optimistic about this. But I think that what you're seeing in oral health is happening across the health system, and it's moving in the right direction. So you can influence it by pushing for change and making sure, you know, don't just cower in the corner when the dentist says no, you're not allowed to have that conversation with the patient. You don't have to do that. We're not in the 1950s. But at the same time, the system's moving because everybody's sick and tired of it. So I think that's something that's really positive.
Fantastic. I think we've got time for one more question before we wrap up. Is there any final question or comment? Yes, thank you.
My name's Tan. I'm current president of the ADOHTA in Victoria, and some of you may know me. I find this discussion being very inspirational because we are very lucky in Victoria where we have very like-minded people discussing these issues that is on the national radar as well, and even discussing things like coming to an outcomes-based approach, whether it's reducing risk, whether it's the financial side, it all comes together in a system approach. And we also should be mindful also that we also have the public being provided, you know, roughly about 20% of service delivered in public. Don't forget the private sector, which can also help in the public system as well. Both federal and state government systems, as they are, that's how it's funded. So the private sector is also a useful avenue to go through as well. And when we incentivize, although we may look at whether it's reducing risk, whether it is still item codes, if you increase the prices of a regular checkup or a scale and clean, and you're removing any item codes that may not be fit for purpose, or whether it's, you know, low sort of impact, then you'll find that more people will be coming for more checkups, and you know, more fluoride treatment. And although it may seem like it's, you know, you are driving that preventive side, less and less people are going to have less demand for fillings or emergency care. And so although there are issues with outcomes-based approaches to funding, we also need to be mindful that in the current system, we also have the ability to shift cost towards prevention as well. And that's something that I think a lot of us, whether it's regardless of what cost it is, if you increase the prevention side, then managers are going to think, what is the best way to get that outcome for the cost as well, because that's an efficiency side as well. And so I think we're very happy for a lot of us here that this conversation is becoming a bigger voice, and I congratulate Martin in terms of such a fantastic conference discussing these issues, and the whole organisation as well. So yeah, that's sort of some of my comments that I'll leave there.
Thank you, and I'll hand over for any final comments. Before we wrap up, any final comments from the panel, if they'd like to? Yes? Thank you.
As a ring-in and a rank outsider, I'm from Queensland.
Still part of Australia.
Still part of Australia, although I think we're still in the 50s. I have to say it's been a breath of fresh air to see the fantastic stuff that's being done in Victoria, and to know that at least somewhere in the country, public sector is acknowledging that the whole philosophy needs to change, that we're not doing fillings on patients. We are there to provide patient care and to help our patients in their journey to better health, and with whatever skills that we have available to us. So it's just fantastic to see the level of interest, the attitudes that are coming out of the people down here, the support that you get. Don't take that for granted, because we don't get it in Queensland. So you guys have really on the pinnacle there for making these progresses and actually being world leaders. So well done.
Fantastic. On that very positive note,